introduce her today. And I think I'll end with this. With all of the impending cuts that our field is facing, it's never been more important for us in rural Illinois to learn from other pioneers, from other states that have gotten this right. We don't need to reinvent the wheel. We need to continue to honor the standard of care that our people need. We need to learn efficiencies and learn how to do more with less. And what she's done, I believe we're going to gain a ton of insight that we can use in our state to advance care. Sheamekah.
Thank you, Dr. Scruggs. Again, I am grateful for the introduction. As she mentioned, my name is Sheamekah Williams. I'm from the state of Oklahoma. I am the executive director for the Evolution Foundation, which is a foundation that serves children, youth, and families across the state of Oklahoma. In the state of Oklahoma, just to give you a little bit of background, we are extremely rural and frontier state. We have 77 counties in the state of Oklahoma. And so I have the pleasure and the honor of serving communities as well as children, youth, and families. And for those of you who have not taken a look at my bio, I'll just kind of make a couple of mentions. I served as the Director of Children, Youth, and Family Services for the Department of Mental Health and Substance Abuse Services, where I served 15 years for the state of Oklahoma. In addition to that, I serve on several different entities as a subject matter expert. Specifically, I want to lift up the University of Connecticut in their mobile response and stabilization network, which I'm a subject matter expert for that. And so I come to you with a background in knowledge in children's behavioral health and have worked on the front lines with communities, families across the state of Oklahoma and in other states. And so really extremely excited to be here today. Again, let's go to the first slide. I'm really going to be sharing my perspective and some of the work that we've done here in the state of Oklahoma around effectively serving rural and frontier communities. And I'm really going to talk about some of the tools and the techniques that we use and the platforms that we use in order to be able to do that. But again, as a part of this presentation, there are some things that are really important to me to share. And so you will definitely be hearing some of that. Next slide, please. As a part of my presentation, there's a couple of things that I want you guys to walk away with. We're going to talk about effective strategies to serve rural communities. We're going to talk about the understanding and the importance of community partnerships and really how to work with the diverse partnerships throughout the different counties that you guys serve in Illinois. As most of you know, each community is different, has a different population and definitely some historical things that are really important. I'm also going to talk about how we utilize technology, specifically the iPad platform in the state of Oklahoma, in order to increase access to individuals and to really stabilize the care of those individuals that were in crisis. And then I'm going to talk a little bit about our lessons learned. So first slide. So getting help can be extremely hard and confusing. I think that when we think about emergencies, personally with our families, when we think about emergencies and we need help, our first immediate thing is to call 911. I think that also most of you guys are on the Zoom here today are probably mothers, aunts, grandparents, aunties, family members, or friends. And so I want you to think about this in the context of your young people or family members or children that you have or grandchildren that you have. The reason why that's important to think about it from that mindset is because, again, when we want help now. This is not a situation, again, if you had a young person that had a medical emergency, such as maybe we're talking about a broken arm, or maybe there's, some issues with their heart, liver, or however, where do we go to? We immediately transition to the emergency room. And I think that most of us will probably be driving 90 miles an hour trying to get our young kids there. That should be no different when we're talking about behavioral health care. I think that oftentimes we forget that the head is connected to the body. And so when in fact things are not going right, as a parent, myself, I think our immediate response is we want help and we want help now. So really think about what help looks like for you and your community. Where do you go when in fact you have an emergency? Who do you call and who do you contact? And and thus the contacts or the calls have the resources and the types of supports that you need in order to take care of your crisis. Next slide, please. This first slide, I think is really important because, as I mentioned, the fact that it's really important for us to really begin to think about the system and the community that we live in. Most of us, some of us may live in rural and frontier areas of the state. What does that look like for you? How do you access mental health treatment? How do you access healthcare services? And so one of the things that for me was to really design a system as in if I needed to utilize it. And I think, as Dr. Scruggs mentioned today, the one thing that I want to bring forward and oftentimes gets overlooked, the fact that I have the lived experience. I was a therapeutic foster mom. I've been a therapeutic foster mom for over 20 years, and I've served numerous kids in my home. And so I really wanted to design a system that was really important to me because at many points in my foster care history, I needed to rely on a medical expert or professional mental health experts in order to support me when, in fact, my kids went through crisis. And so my first interaction was I had a situation in my home where one of my kids was, again, hallucinating and was very psychotic. And so at that point in time, I didn't have anyone to call. I didn't have anyone that would contact me or come aid me during that crisis. So my first step was to our emergency room. And so again, from that experience, being the director of behavioral health, knowing that we had a crisis system, I really wanted to look at how do we improve our crisis system? How do we make sure that families have access to the types of resources that they need in order to care for their kids who are having mental health challenges or behavioral health challenges? And so this illustration is from the University of Connecticut, and it shares you, again, when it comes to children in crisis and caregivers call, they need a way in order to access that support. In many cases throughout the states, 988 is an access point. It's a single point access for children, youth, and families, as well as adults across the nation. But in addition to that, the state of Oklahoma worked in partnership with New Jersey and Connecticut in order to really look at what were they doing that was so significant to a point. What could we take away? I call it my beg, borrow, and steal concept. We're really looking at models that were working in other states in order to display those models in a state like Oklahoma. And so youth mobile response and stabilization was the model we chose, with many adaptations to make it fit the state of Oklahoma. And so really what I'm going to be talking about today, and I think my colleague Liz Manley is on another Zoom, where she'll talk about mobile response and stabilization and the process for really responding to children and families when in fact they need the response. And I can promise you this, when in fact when youth and families call, we must show up in order to make sure that they have the types of supports that they need. So again, in mobile response and stabilization, it's really about responding face-to-face, that just go concept, in addition to providing a platform or a range of services in order to help with stabilization. And that allows us to divert kids from emergency rooms, divert kids from law enforcement, and also really look at opportunities to leverage lower levels of care instead of inpatient psychiatric programs. I think that inpatient programs are definitely needed, but I also think that there are ways to really look at the types of supports that family needs in order to maintain kids at a least restricted environment in their homes and in their community, with hope for tomorrow is extremely important for families. And so, and the last thing I'll say about that is I think that from my experience, the first time my child went inpatient, it was not only traumatizing for her, it was traumatizing for me, because I had to technically be away from my young person for 3 days. And it's not like a regular medical hospital where if my kid went into an emergency room, I could stay with them all the way up to ICU. This particular experience was my kid went in, and for 24 hours, I had no contact. And after that, again, I had family treatment services with her, but they were out of the home and away from me. And so that was definitely a traumatizing experience for me. And so I really wanted to design a system in the state of Oklahoma where children and families had an option to be diverted away from high psychiatric inpatient hospitalization, and they would have the supports that they needed in order to maintain at home and in their community. So I definitely encourage you to take a look at Liz Manley's presentation as it is going to be recorded. Next slide, please. In the state of Oklahoma, as I talk about our crisis system, and I think you'll see many crisis system models across the nation, but one of the things that was really extremely significant for us is the utilization of technology and building a technology infrastructure so that we would have access to individuals throughout our state that have the ability and the knowledge to support behavioral health crisis. So the background of telehealth is really where telehealth professionals have the ability to be remote. They can address it has the ability to address the shortage of healthcare workers. I know that we are in a crisis around the nation where we don't have enough licensed clinicians or we don't have enough PhD level individuals that really support our behavioral system. So telehealth was really a way for us in the state of Oklahoma to leverage the utilization of our licensed clinicians who were available 24/7, but they didn't necessarily have to be in person. In Oklahoma, our model stems on a kind of a first responder model where we actually sent out bachelor's level individuals as well as peer professionals to be the first responders. And they all have access through technology utilizing our iPads to a licensed clinician who is available for assessment. And I'm going to talk more about that later. Next slide, please. I think it is also important to understand that again, many states have technology vendors and vendors that have the ability to provide options for a technology platform that can be utilized through crisis. Technology can be used to really reduce psychiatric hospitalization. In the state of Oklahoma, we are a CCBAC state, so we have about 16 CCBACs across the state who serve 16 counties. One of the most important things for us through COVID is we didn't have to shut down through COVID because we were able to utilize our iPad technology as well as our push apps in order to allow individuals to receive services when we were sheltered at home and out of the office. And so technology can definitely be a benefit for individuals, and it can also sit in a public platform. We have partnerships throughout our system, as I'm going to talk about, where we actually have the iPad technology in places and spaces that are more likely to see children and families as well as adults, so that again they have that immediate access to a clinical person who can actually triage or provide an intervention through an iPad technology. Next slide, please. Our iPads are in our crisis system, as I talked about the design. Again, across the state of Oklahoma, we have 77 counties. During COVID, we were able to provide training and technical assistance to our law enforcement officers, training them in CIT intervention. In addition to that, we were able to equip any of our on-duty law enforcement officers with an iPad for the purpose of providing that face-to-face interaction between a licensed professional, a person who had the skill set and had the ability to decrease a crisis, or who had the skill set to assess the crisis and to support our law enforcement officers. And I'm going to talk more about some specifics with that. In addition to that, when you're thinking about behavioral health crisis anywhere at any time, I think it also has the ability to reduce the cost of your program by utilizing this technology. We know that when you're in rural and frontier area, travel and distance can be extremely tough. In many cases in the state of Oklahoma, by the time you get from one place to the next, it can take you an hour to get to a crisis. And so the ability to use technology to provide that immediate intervention can be extremely important. Next slide, please. Again, as I mentioned, that our platform is an iPad platform where you actually have the ability to work with your behavioral health professional team, which could be your peer support, your therapist, your family support provider. It can be your case manager. You can also have your medication site visits done through the iPad technology. I think that COVID was an example where CMS were able to expand our ability to utilize it, and those types of expansions still exist today. So states can actually adapt the face-to-face interaction through technology as a way to provide services and behavioral treatment. Next slide, please. Again, as I talk about the iPad technology in Oklahoma, I think that clients have the ability to set appointments through our technology platform. Our platform is an actual iPad that has been erased. They're refurbished iPads. They've been erased. The only thing that are available on that iPad is the apps that allow you to contact your treatment team. There are apps that provide opportunities for wellness, so you can actually play wellness games on your app. In addition to that, you can really look at your appointments. You have the ability to to, as I mentioned, face-to-face calls for screening and assessment, as well as you have the ability to sign your EMR forms. So any consent forms that you would need, they have the ability to push so that you can sign that information. And it makes it really easy for the provider network to really take a look at your documentation, specifically your screening and your assessment documents. It allows them to see it and view it at the same time that you're able to view it and see it. And then the iPad app has the ability to electronically submit your information up into the ENR. So that was extremely important for us. Next slide, please. As I mentioned, again, one of the things that we wanted to do, and the reason why this technology platform was really extremely important for the state of Oklahoma, because again, COVID was definitely a lessons learned for many of us, but we never want to reduce or stop the availability of mental health treatment services. And so we wanted to really create an opportunity to increase access in rural and frontier areas. And so COVID was a time when the bandwidth was being strengthened. And so there are many rural places in the state of Oklahoma where you still have a cell tower and you're able to connect through your iPad or a push notice. And so that was important. And then also we wanted to make sure that because of our travel distance, we had this equipment in the hands of law enforcement, as well as you will see in one of the documents later on, is one of our providers. They have over 9,000 iPads in the hands of their consumers. So they utilize this on a daily basis. And oftentimes people, they talk about the expenses. And again, in the report that I will show you, those expenses are no longer a conversation piece, because iPad technology has the ability to allow you to see your individuals more often. And a lot of times people have appointments once a month. Well, this technology allows you to see people more than once a month. So it actually increases utilization. And so that's really important. Next slide, please. As I mentioned, Oklahoma being a statewide implementation, Oklahoma is a CCBAC state. We also provide crisis services across the state to all 77 counties. So I'm going to give you some examples of what that looks like and how we partner with our community. Next slide, please. This particular slide talks about our infrastructure here in the state. We definitely have a call center that actually triages our calls. We have staff and workers that we work with in order to provide workforce development, training, and technical assistance. And we utilize our family and peer support partners on that front line. I think when we're talking about a workforce shortage, the best way to increase your workforce is to increase the number of family supports or peer support partners that are on your team. Again, all of those have the ability to do virtual access to a licensed clinician, as well as to utilize our iPad for the purpose of providing treatment. We are data informed, and data definitely informs the decision making here in the state of Oklahoma. Also, we have data platforms that allow us to look at staffing patterns. I mean, through our call center, we're able to look at where our calls are coming in, the times of day that these calls are coming in order to look at what type of staffing pattern would be needed in each of our counties. And our data platform is real-time data. From the time that you take in the call, that call is available and it goes into the system through our call center, and our mobile responders are able to take a look at that. So again, if they're en route or they're getting ready to be en route, they have the ability to look at information about the person who's made the call, and they also have the ability to talk to that person as a part of our platform. Again, we offer stabilization services. I think it's one thing to respond to a crisis, but it's another thing to look at the aftercare. Our stabilization services are pretty immediately. So individuals that are in crisis that we respond to today, they have access to do a walk-in or come into our clinics and work with the clinician the very next day. Again, our CCBACs in the state of Oklahoma offer those walk-in services. And so we're able to really work through stabilization with any individual that is in crisis in our state. Next slide, please. As I mentioned, in the state of Oklahoma, there's some critical things that were extremely important for us when we began to launch the iPad technology and the partnerships across across the state. The one thing I can say is, as each of our 77 counties are unique, it was really important for us to really work with our community partners in order to really help them to understand what mobile response and stabilization was. What is crisis care? We've done a lot of trainings for our community partners, such as mental health first aid. We talked to them about crisis services for kids, and we helped them to understand that our services were responding to stabilization. So we will respond when you contact us, but our whole goal is to get that young person or that person stable in order for us to continue with stabilization services and follow-up care. And so it wasn't kind of this community crisis concept where oftentimes community members want individuals placed in hospitalization. And so we had to help our communities to understand, as the experts, we have the ability to assess, to make that determination. I think you need to lean on us for that, because oftentimes people feel like when people are in a psychiatric emergency, the first alternative should be hospitalization. And we don't believe that here in the state of Oklahoma. And so what this design looked like, Oklahoma has 509 school districts in our state. That's quite a few schools that we had to partner with and really help them to understand our platform. In addition to that, we work with both state, county, city, and tribal law enforcement agencies. We wanted to make sure that our law enforcement officers, who were often known as the first responders within our system, because most people, I mean, honestly, as a family member, the first person I'm going to call if I'm in crisis, whatever the crisis may be, and however I determine that I am in crisis, I'm going to call 911 because I want help. And when I want help, I want help now. And so it was really important for us to help our law enforcement agencies across the state of Oklahoma to understand that as mental health professionals, we were available to support them in the response to those types of situations. Many of us have seen the numerous crises incident that takes place when in fact law enforcement are not trained and not prepared to care for individuals who have mental health and substance abuse challenges. And so we wanted to be a platform with the state to provide that training and that understanding for our law enforcement officers. We believed in safety, and our law enforcement officers are designed to support us in safety. And so through this partnership, we were able to look at situations that were unsafe. And when in fact our law enforcement needed to go in, they were trained and equipped to work with it. And once they were able to create a stable environment, we were able to come in as mental health professionals and aid them in that situation. And so that was extremely important. I think another thing that was extremely important for us is recognizing that in the state of Oklahoma, we have 38 federally recognized tribes. Okay, that comes across. That is extremely important because we are a state that is extremely rich in culture. Not only do we have 38 federally recognized tribes, we have some historical trauma that comes into the context of our tribes. So we didn't want to be a system that said this is what we're going to do and this is how we're going to do it. We wanted to be in a system to say this is what we're thinking. What do you have? What can you tell us? And how important is this to Native families? And how do we better support Native families as we are providing crisis services across the state? And so we took a partnership on with our tribal partners and really allowed them to provide us with feedback and insight, created marketing material that would really help to address the tribal population. In addition to that, most of you guys know Oklahoma has a history that goes back to Black Wall Street in the city of Tulsa. It was extremely important for us to connect with that community to say, how can we aid you better? Because we know when it comes to some of our communities and some of our population, there's a historical trauma and there's some trust issues that rely on that. And so community partnerships do matter. And I think that the importance of community partnerships is one, to help us to understand how can we better serve and support you? What are your recommendations? But the other thing is to say, not only are we going to support you, not only are we going to work with you, we're going to show up. And I think that's the critical thing. As a parent, as a caregiver myself, the one thing that was extremely important was that our crisis system showed up. And so as you guys hear my voice crinkling, I'm thinking back in my parent days, because that was the single most important thing for me as I develop our state children's mobile response and stabilization system. I wanted our providers to show up, because when you show up, you can make a difference. And to me, every call was life or death. Every call, because you don't know the circumstances of the situation behind it. And so not only was it important for us to show up, it was important for us to create partnerships so we can keep our kids and our families safe when they were in the community. Next slide, please. Again, I talked about our technology implementation for law enforcement. We have approximately, and it's actually more than that, we had approximately 22,000 tablets in the hands of law enforcement officers across the state of Oklahoma. That number has went up. Our goal was to make sure, again, COVID had created the ability to utilize, I think it's ARPA funding for the purpose of this type of implementation. And that funding was designed to make sure that every on-duty law enforcement officer had the ability to have a mental health professional who aided them when in fact there was a mental health crisis. And so again, this is important. In addition to that, these devices are in the hands of individuals. In our state, we have what we call our most in need. Our most in need are those individuals that often come through our crisis system. They're often individuals that have been placed in higher levels of care. And so we wanted to make sure that we really created and diverted from that higher level of care and provided support to those individuals that were considered most in need. And so COVID was an example of, we felt like we were extremely prepared because our most in need had access through our tablets. They can contact us anytime, multiple times a day if they need it, or we have the ability to respond to them. And so that was really important to us. And of course, definitely driving down inpatient hospitalization. Next slide, please. Again, when I say our implementation of technology was huge for us as a state, when we talk about access, 900% increased access, and that number is continuing to go up. This number was back in 2023. Now, these are 2023 numbers. Again, what does that mean to me? That means that there were more people in the state of Oklahoma who had access to mental health supports and treatment because we increased our ability to access them. That specifically, most of that increase comes from our rural and frontier areas of our state. The culture is definitely different in rural and frontier areas. And so we had to do a lot of community training and a lot of community support to help people to know how to connect with us, how to contact with us, who to call if you had questions. How do we better support you? As our farmers in the state of Oklahoma were going through it during COVID. COVID was during the time we also had droughts in farming. Many of our farmers had to sell off, had to sell their cattle, had to sell because of the hay shortage. Again, what looks like a crisis for you may look totally different for others. And imagine a longtime farmer who has a generational history having to sell off their livestock. Again, very challenging. And we definitely seen our farmers that were connecting with us during this time. Next slide, please. I think it's also important to understand that as a parent, as a citizen in the state of Oklahoma and as a citizen in the United States of America, we have been trained to utilize our emergency rooms when in fact crises are arising. It is something that all of us know, and when in fact we need help, we call 911. When in fact we have a body emergency, I would say, a physical health emergency, we go to emergency room. And so people were trained that when in fact you have these types of emergencies, even psychiatric emergency, in order to get help, you go to emergency room. So what we wanted to do is really address emergency room boarding. And as a part of addressing emergency room boardings, we had to create MOUs with our healthcare organizations across the state of Oklahoma. We understand that at 2:00 at midnight, it may not be safe to go down the dirt road, look at the red barn, turn left at the tree in order to get to an individual in crisis. But we knew if our law enforcement officers didn't get there, those individuals were going to show up in our emergency rooms across the state. And so in the state of Oklahoma, our emergency rooms are not quite equipped. Most of our emergency rooms don't have access to clinical staff who have mental health or behavioral health expertise. And so we wanted to be, and so our CCBACs in the state of Oklahoma began to do MOUs with our healthcare entities. Those MOUs had the ability to create a technology interface so that, again, if an individual came into the emergency room and they were in a psychiatric emergency, they had the technology to interface with the clinical staff who can offer support and assessment capabilities. And so our MOUs also talk about our ability to screen and assess the situation to make a recommendation to the house physician. And we understand the importance of those physicians and the roles that they carry. But what we said is we wanted to be a partner in this. And in many times in partnerships, a lot of times hospitals, they make a determination. And sometimes those determinations mean we want to elevate this person to a higher level of care. And so what we said is if we can utilize our resources and supports in order to provide a recommendation for a diversionary plan, that this person would not only have a plan for diversion, we would also provide stabilization services. And if it means that we evaluate escalate their medications. If it means that we had to treat them or work with them daily, then that's what we would do. In addition to that, we have a statewide psychiatric access resource knowledge line. That line has the ability to allow our physicians across the state of Oklahoma to look at different cases and to talk about those different cases. And really it has been a line that has helped psychiatrists to communicate with primary care doctors and help them to better understand how to support individuals with mental health disorder. In addition to that, our CCBAC have stand-in psychiatrists who work with primary care doctors and really consult back and forth to help with the decisions that they have to make in our emergency rooms across the state. So that's pretty important. And then really creating a process for communication and really to go back and forth. So hospitals really felt safe to divert individuals and really move towards stabilization. Next slide, please. Again, we're talking about over $23 million in savings. I mean, we're talking about 2023. This data comes from 2023, utilizing the technology, diverting from hospitalization and inpatient care. So it has the ability not only to save money to the system, it also has the ability to support and cost savings to organizations and agencies. Next slide, please. Again, as I mentioned, we have the ability, we have a data system that allows us to look at really data across the state to see where our numbers and our volume is, to look at it per capita, to look at where we need to provide more technical assistance, where we need to provide additional marketing. And so this was really important to have a platform where we can actually see, because it definitely helps with staffing. And this next slide will show you that. This slide right here is really our hotspot data slide. Again, as I mentioned, I can tell you real-time data around the days of the week, the time of the day, that there are more than likely times we're going to be crisis. In addition to that, we do a lot of preventative work when in fact our call line has a number of calls coming from the same county. We can articulate that all the way down to the same school to be able to provide an intervention within that school environment to help educators, professionals to say, hey, last night we received 3 calls on 3 kids that were in your school. Is there anything that's going on? And one of the things we were able to digest and identify is sometimes there are trends that are happening on social media and kids are taking parts. Kids are participating in these trends, which often could lead to a crisis. I don't know if you guys remember when kids were digesting Tide Pods, eating Tide Pods. And again, those situations will come up and you can see those trends through your call center, through your data in order to be able to provide prevention and intervention type support. So data is extremely important in that. Next slide, please. Again, we look at our crisis situation. We utilize the Ohio scales to look at problems and function in our young people. We look at it at the point of intervention and we actually look at it long term. Our whole ultimate goal is when we have individuals that are not associated with a treatment provider, we try to get those people in treatment as quickly as possible through our CCBAC model. And I just wanted to point out the Ohio scales and how we are able to assess the effectiveness of the model that we have here in the state of Oklahoma. Next slide, please. This is our functioning scale, and those of you who are not familiar with the Ohio scales, you can definitely Google those scales and it'll tell you how we're able to assess and determine the level of problems and functioning within youth and young adults. These scales have the ability to survey both the parent, the caregiver, as well as the youth. And so again, these things are really important when you're really trying to look at, does a crisis system work? Are kids moving to a level of stability and stabilization? Next slide, please. So I'm going to run through our crisis slides, our evaluation slides, because I think that it's really important to talk about some of my lessons learned and some other information. So if you want to open up these slides for the sake of time, I'd appreciate that. Again, this kind of gives you our caregiver rating scale, how our caregivers see the level of function that's happening in their family. I think it's one thing to say a kid has a CAR score or a assessment score that says that their function and their problems are better, but to be able to ask the family about their family dynamics, are those things improving? Is the family able to communicate better? Has things gotten better in the household? Has things gotten better in the school is important to assess as a part of your crisis system. It's one thing to take a person from crisis to stabilization, but you want them to be able to function in their everyday lives, and our data slides will show you that. Next slide, please. You can open this one up. And then, of course, it's really important to get the youth and caregivers' perspective about their own behavioral health. And these data slides will show you some data specifically around that. And so their perspective does matter. It's not always about feelings. It's really about how they're able to function in certain environments, how they're able to communicate and socialize with their friends. Those things matter when you're really working through the stabilization process. Next slide. And then we want to look at the difference in how the youth perspective and the caregiver perspective. What makes it different from the caregiver saying one thing and the young person is saying another? We really look at how to assess that and how to get them to more of the clinician to help them to get to a path where they're both speaking the same language as it relates to the stabilization of the youth. Next slide, please. And again, we look at it from age and gender. We want to look at some of the differences across the age spectrum from 7 all the way up to the age of 18 when it comes to our young people and the different things that they come in with and really what are kids from 7 to 9? I mean, we even look at 0 to 5. Those numbers are a little bit lower, but we look at what are these individuals coming in with our system? Why did they call a crisis line? Are these self-harming attempts? Is this depression? What is the case? And so we look at that from age and gender. Next slide, please. Okay, and I actually ran through our data slides. You guys can take a look at those slides as they will be provided with you. But I think it's really important for us to talk about the considerations and leave time for you guys to ask questions. I talked about the fact that our most in need clients have iPads and really help to support them during the stabilization process. Those iPads allow them to have access. So again, when they're at home and they're in their own environment and they feel a certain way and they're working through stabilization, they can contact their clinical team. They don't have to run to an emergency room in order to get support. They can contact their clinical team in order to do that. When you're looking at access face-to-face and really preventing the relapsing crisis, those things are important. Appointment reminders that are pushed. I know my day-to-day, sometimes things get heavy and I often forget that I have an appointment the very next day. So the capacity and ability to push for appointments, some reminders are really things that are really important when you're utilizing technology. And then reminders for taking medications. That's extremely important. So let me tell you, one of the things in partnerships with our schools, the number one thing that they would tell us is oftentimes the kids with behavioral problems come to school and they haven't taken their medications for the day. And so imagine if you're, as a caregiver, you had a reminder message that came to you on your phone or on your iPad early morning, 7 o'clock before you got little Johnny off and ready to go to school to say, hey, let's make sure we give him his medicine. So that's really important. And then opportunity to receive increased service without the burden of transportation. Now, again, I live in rural Oklahoma, so I know it takes me 20, 30 minutes to drive to the grocery store. And so again, sometimes transportation can be an issue when you're trying to do follow-up appointments or appointments. So this technology platform can be something that you can consider as a way of reaching your population. Next slide, please. I think things that we learn, rural and frontier communities are different. I think that when we think about, one of the things when I think about as a person who lives in rural Oklahoma is that, community does matter. We're pretty, really tight-knit community. We work together well. And when we understand things, we can do things different. I'm pretty sure it's the same way with you. So one of the things that is across the state of Oklahoma on a Friday night, everybody is at the high school football game on Friday night or the high school basketball game. So we utilize that as a platform to speak to our communities, to educate them, to tell them that mental health does matter. We help them to understand the importance of a checkup from the neck up. We help them to understand that our providers were here to partner with them, to aid them during those times of crisis. Those things really matter in rural Oklahoma. We were able to help our farmers to understand that, again, you don't have to suffer in silence because there's a system that is available to support you when in fact you need us. Just call us. And then not only that, we were able to look at opportunities for short-term interventions. And when I say short-term interventions, you guys remember what our kids went through COVID. Our kids were anxious and anxiety levels. They couldn't touch, they couldn't hug, they couldn't support one another. And again, sometimes parents and caregivers need to understand what's going on during that time. Why is my kid isolating to a room? And so system partners and crisis partners have to provide that education and understanding. I think also our ability to work with our law enforcement officers and our emergency responders is important. Let me say this. It's not just important to equip your law enforcement officers with iPad technologies. It's important to equip your IMSA responders to help them to understand they may be responding to an emergency and it might end up being a mental health emergency. Fire departments are oftentimes first responders in safety, helping them to understand there is a system, there is partners within your community that can aid these individuals when you don't have the skill set or the resources to support them. And so that well done community education, community support is important. It's just not important to talk about it. You have to show up and be about it. And what I mean by that, if you say, this is what we offer, you tell me, when you call, I will support you. And if you need me, I will come. That's what I expect you to do as a parent. Because otherwise, I'm running to the hospital as quickly and as fast as I can. So again, in order to divert away from ED and hospitalization, you really need to think about how do you equip your medical professionals with the resources that they need. Rural schools, as I mentioned, we have over 508 schools in the state of Oklahoma. Our kids are in classes Monday through Friday from 8 o'clock to 3 o'clock, 8 to 4. However, we want to make sure that our teachers, our education staff have the resources and the understanding. So providing training to your schools about your crisis system. And again, when they contact you, creating a process and a pathway where you can show up and enlist the support of caregivers and families. And then most important, caregivers, parents, whether you have kids that were infants all the way to teenagers, we really have to think about how we're supporting them. Are we creating the same system that we would want for ourselves? That's really important. Next slide. These are some resource slides that I'm going to leave you with. Again, you can always go to SAMHSA to look at the National Guidance on Youth Behavioral Health Crisis System Development. They provide some really great insight and platform. And the great thing about it is, the state of Oklahoma provided some insight on this. So I think it'll be helpful. The next thing is, this is an important read, and I encourage the next slide right quick. This is an important read, and I encourage you, those of you who are CCBAC mental health professionals, providers, I encourage you to read this. Grand Mental Health is a community mental health agency, now a CCBAC in the state of Oklahoma, that is innovative. And they talk about their utilization of iPads back in 2020 and how they utilize it to increase law enforcement costs on transport, to increase agency costs on transport, to increase access to services and support. They also talk about client satisfactory. We're in a world of technology. The coolest thing about this technology platform is people love it, because guess what? We all have our phones in our hands daily. And it is culturally appropriate. And so take a look at this read, and I think you will enjoy it. Next slide, please. Okay, guys. Again, rural Oklahoma, I'm that girl. I have cattle. I don't have this kind of cattle, but I do have cattle, and I live in rural Oklahoma. I serve and support rural Oklahoma. Again, I'm Sheamekah Williams, President and CEO of the Evolution Foundation. Extremely delighted to be a part of this conference platform today to share my experience and my expertise in the state of Oklahoma around crisis services for children and families and adults. So again, thank you for having me. And Dr. Scruggs, I will turn it back over to you just in case we have questions.
Wow. Thank you so much. And I'm jealous. I want cattle. That'll be another thing we'll add to our agenda for our conference.
Our conversation piece.
Oh my goodness. Thank you so much. Thank you doesn't do it justice. What an incredible wealth of information we've seen today. Just anything from high level policy down to just the practical. How do you do this? What does this look like? How does this play out in crisis care? I have 65 questions, but we're going to continue this offline. I want to open it up for those that are attending today. And I will look at the chat just to see So Allie said, this has been great. Thank you so much. Looking forward to working with you. I'm looking for questions here. Let's see. Yes, Jacob commented on the field of peers not only exploding in growth and will fill a gap, but
yes,
the research of peer supports efficacy. Amen. That has been a such
absolutely
gap filler for we've seen
yes.
that girl.
So Jacob, let me say this to Jacob, and let me say this. People often ask me, as I served 15 years as the director of children, youth, and families for the state of Oklahoma, people often ask me if there was one thing you were proud of, what it is. My most proud thing is creating this crisis system for our state. The second thing they say is, what would you have done different, or what do you wish you would have done? I say this and I stand on it. I wish that I would have the ability to increase the number of peer supports in the state of Oklahoma across the workforce. The reason why peer supports is because when you're talking about a crisis system, again, trained peers have the ability to support individuals because they've been there and done that. And I think oftentimes people want to build this system up with licensed clinicians. Again, in the state of Oklahoma, our peers can do we have language that allows us to do crisis diversion. Our case management level our peers can do crisis de-escalation, and they're good at it. Our case management level do crisis diversion, and our licensed clinicians are the ability to screen and to assess those situations. Again, utilizing individuals at the level that they are professionally appropriate for. And again, in a crisis system, in my opinion, you literally build those out with peer supports on the front line with access to those licensed individuals or those clinical professionals that can provide the level of support from their knowledge base. So that's really important. Yes, expand peer support. I believe in that.
Absolutely. Jacob's giving you 100% with a smile. Anyone else have any questions? We have about 6 minutes. Let's open up the floor. While people are thinking, so I immediately, because I'm a process and model builder, innovator, I think of, okay, so you have this technology, the hardware, right? The iPads, excuse me. They're refurbished, which is great. I mean, what a smart, way to keep costs down. The second thing you have, it's loaded with the apps that provide the care. It's the clinical care app, the wellness activities, brilliant. And then you talked about, you made sure the state has the infrastructure and technology. I think that was your quote. And I'm thinking in my head, can you describe that in a more granular manner? Like, who's paying for the hardware, the cellular service, and the IT maintenance of those? And can I the part B of my question, and then I'll just turn it over to you, is what are the criteria for determining who gets an iPad? And then you talk a ton about we show up. That's from Arukah's standpoint, that's what we do. And that's why we believe we can, bridge that access, is because it's putting a person in front of another person. So you said that, but you also said you use iPads to enhance that. So can you talk about the criteria for when you go versus when?
Absolutely. I'm going to try to hit on this pretty fast because I've seen Allie had her hand up, and I want to make sure she get her question.
Sorry, Allie.
So initially, Grand Lake was one of the first CCBACs to implement iPads. And this technology not only has the apps and the apps that allow you to have the clinical support, signing and all that, the technology also has GPS. And so people think about, what if you lose them? What if you this? Well, we have our CCBACs have contracts with a vendor called MyCare. And through this contract, it also allows you to be able to have GPS access. So if you have an individual, say, for instance, I've had this situation that was homeless, and this was in homeless encampment. We hadn't seen that individual on time. Over time, they had missed appointments. but we were able to track their iPad down. We were able to go to them and connect with them in order to retrieve our iPad when in fact that is important. In addition to that, the iPad capacity will pay for itself. When you read the Grand Lake article, when you purchase a refurbished iPad, you're purchasing at a lower cost, but the ability to increase access to that client and bill for those services over time will allow you to recoup that cost. The other thing is, I think that during COVID, ARPA funds in the state of Oklahoma helped us to support the infrastructure for iPads for our law enforcement officers. So that was a huge investment. All of our iPads are purchased by our treatment providers. Our CCBACs, 16 CCBACs, have the ability to purchase iPads or push apps. They have the ability to hand it out to the most in need or individuals that are in crisis stabilization, or like Grand does in their model, they hand these out to a lot of their consumers for the purpose of interfacing with their clinical team, interfacing with the crisis centers. And so this infrastructure is there. One of the first things that we did is we elevated our state plan in order to include face-to-face interaction through these types of technology platform. And that was something that we had done a little bit prior to COVID, so we were ready when COVID. And so building that infrastructure. The second thing is, I can promise you this, you build what people need and what people want, and you can definitely find a way and a mechanism to pay for it. And that was important to us. We wanted to build the best product or the best type of initiative, intervention, whatever, and really look at the pieces and strategize around building it out. And again, I think that most of us know that manuals are available on website. You can look at the CCBAC manual for the state of Oklahoma. It'll provide you some insight around crisis care services and how those services are paid for. But I think also really looking at the upfront investment and the partnerships. We did some blended funding with some of our other child serving agencies, state agencies, to really bend some funding together to really create the best opportunity for children and families in our state. So that was really important for us, Dr. Scruggs. So I hope I answered your question. Thank you.
No, that gives me some substance to think about. And I wanted to get to Allie's question, and then Lauren seconded her question. Did you get any pushback when you introduced the use of technology as such a critical part of your system? And if so, how did you combat that?
So we were, like I said, Grand, if you look up the Grand model, Grand Lake at the time, their Grand Mental Health now, was the first provider who introduced this platform. They looked at their data, and they had more clients that were in services with their organization that were on the most in needs, the high needs list. That means these people were cycling in and out of inpatient hospitalization. And so they wanted to be innovative and come up with a strategy to best serve and support that. And they started the pilot in a sense, and really started handing it out to their most in need. They seen treatment, appointments, access increase. They seen people were keeping their appointments with their treatment team. They seen that it cut down on malus. Now there are some stipulations where